So it's time to move on to the penultimate session of the day. This is going to be about emerging hotspots in diabetes, and to chair the session, we have four chairpersons. May I call upon Dr. A.R. Balamurugan and Dr. C.S. Gauthaman, Dr. T.K.V. Sharavanan, and Dr. T. Jayapakiyam.
So we'll move on to the next session. We'll welcome you all for the next session. We have 5 interesting topics. All these topics were normally not talked about in most of the diabetes forum, and they are always the obscure complication of diabetes. The first topic is more important because it affects one person's self-esteem and causes a lot of psychological issues in a person. It is hair loss in diabetes. To talk on the topic, I now request Dr. Gauri Shankar, the most energetic speaker I've always seen, a good friend of mine. And over to you, Gauri. For the next
Thank you, sir. Respected chairperson, respected Anand Moses sir, Parandaman sir, thanks entire team for giving me an opportunity to talk on this topic. So, another hair loss, diabetes, I did a literary search, so I will present whatever I have learnt. Okay, so the disclaimer is I'm not a dermatologist, so please don't ask me how am I going to treat these conditions. So we will come to the core topic. The average human scalp contains about 1 lakh hair. Unless you have a hair loss of about 50 to 100, we don't call it as a hair loss. That is something which we need to fundamentally know. So what is called as a hair loss? The second point is hair grows at the rate of 1 centimeter per month. This is something, the second point which we need to know, we will reiterate it later. And the hair grows from, remember this mnemonic for the youngsters, ACT. It grows in 3 phases. One is anagen, catagen, telogen. Anagen is the growth phase, catagen is the maintenance phase, telogen is the shedding phase. So ACT, remember these 3 phases, anagen, catagen, telogen. I did some research, some browsing. What research? Browsing. So it showed like early androgenic alopecia as a marker of insulin resistance. This article was published in Lancet in the year as early as 1990. What is this early androgenic alopecia? So if Dhanush comes and if he shows his hair like this, if his scalp, patta, netti mattum therinjaduna, that is stage 1. அதே இப்படி தூக்கி காட்டினான்னா ஸ்டேஜ் 2. அதே நம்ம அண்ணாத்த விஜய் வந்தார் அப்படின்னா அந்த சொட்டை மட்டும் தெரிஞ்சதுன்னா 3. அதே பெருசாச்சுன்னா 4. இது ரெண்டும் சேர்ந்ததுன்னா 5. அப்புறம் நம்ம தலைவர் மாதிரி இருந்தால் 6. இதுவும் போயிடுச்சுன்னா 7. ஸோ திஸ் இஸ் ஆண்ட்ரோஜெனிக் அலோபேஷியா லைக் திஸ். பட் த பாயிண்ட் தட் வி நீட் டு நோ இஸ் androgenic alopecia is very, very specifically in this article as the people who had a higher weight gain, if there is a obesity, they were associated with higher increase in the incidence of androgenic alopecia. That is one thing which was fundamentally shown in this article. The second point which is very drastic is, which is very characteristic is, if people are taking antihypertensive medication, if people are taking anti-diabetic medication, if people are taking anti-lipid medications, so whether it is hypertension, lipid or glucose, the incidence of or the odds ratio of having an androgenic alopecia is higher. And not only that, if the insulin resistance, if various factors associated with insulin resistance are increased, the androgenic alopecia incidence is higher. Also, if the serum insulin level in the body goes about 10, it is again the odds ratio of becoming an androgenic alopecia is higher. So this, as the disease progresses, as this androgenic alopecia comes, what actually happens is the length of the anagen, we said ACT, the length of the anagen is shortened, whereas the hairs in the telogen phase is maintained. So when the anagen phase is shortened, there is a miniaturization. The hair length or the growing phase is shortened. And because of this, the hair loss happens. But most important thing that we need to know is, once it hits, it is very difficult for it to go back. So what do we need to know? So all these comorbidities, our diabetes, insulin resistance, everything has to be controlled if you don't want to land up in that stage. So that is what all that we need to know about androgenic alopecia. There are other articles also to substantiate these findings. Then comes the second hair loss that we need to know. The second thing is something which we characteristically see in our clinical practice. This is the alopecia areata. you have a small patch of hair loss. It can be one or multiple. This comes typically in youngsters. So people less than 20 years are mostly affected because of this alopecia areata. Men and women are equally affected. But what we need to know is this alopecia areata, when the skin biopsy is taken, the periphery of the alopecia areata was showing more amount of lymphocytes, which shows that there might be an autoimmune condition related with this. So when we see a patient with this type of hair loss, always look at whether these conditions are there, and that includes diabetes. See whether the patient is having an insulin resistance. So there are articles to show that this can be a sign of insulin resistance also. That is the second point that we need to know. Then we spoke about male pattern hair loss. Then we spoke about alopecia areata. Then comes the female pattern hair loss. In female pattern hair loss, what happens when we look at them? Women come and say, "Mudiya uludung doctor." But if you see, like they all will have fine hair. Ask them to bend and see, they will have everything. It is all gone over here. So the frontal portion will be preserved, and it will be going like an inverted triangle in the backwards. So that is what happens in these women, and 50% of the women face it in their lifetime. So how do we need to assess, or how do we need to check whether they have a female pattern hair loss? There is something called as mudiya pudingi pakanu. So hair pluck or pull test. These two terms are used. So when you try to pull the hair like this, you hold 50 to 60 hairs. See which quadrant it is getting pulled. So if it is going to happen only over here, it means that they have a female pattern hair loss. And when you pull, if you are pulling 60 hairs approximately, if more than 10 hairs comes, it means it is a positive test. So that is what hair pull test shows. But in these women who suffer by this, there will be an associated abnormal menses, there might be an infertility, they may have an hirsutism, unresponsive cystic acne, virilization, and galactorrhea. What are all these things associated? You can relate to hyperandrogenism. When hyperandrogenism comes, these all comes. Where do we see the hyperandrogenism? We see in PCOS. What is PCOS? It is an insulin resistant state. So it is what is all the common link between all these things? It is the insulin resistance which drives this. So please look for insulin resistance even in the female pattern hair loss through the mechanisms that we have said. Then there comes an interesting entity in the current decade, especially after COVID. This is telogen effluvium. So what does this shows? Telogen effluvium occurs when there is an increased number of hairs that enter into the telogen phase. So from anagen phase, it doesn't go into catagen phase, but it goes into telogen phase. Once the hair goes to telogen phase, there won't be any more growth in the anagen phase, and eventually the hair will fall in 3 months. So if there is a hair fall that they are reporting only in the 3 months, not only in the scalp, it can happen in the body, it can happen in the pubic hair, it can happen elsewhere in the body also. So when such sort of hair loss happens, think about telogen effluvium. So what is more important is telogen effluvium comes with crash diets. Nowadays this is what we discuss for all our diabetic patients. So when there is a crash diets, or as Gautaman sir was telling, like psychological stress, this is what is happening to all our patients. The AC inhibitors and beta blockers also can cause, as well as the hypothyroid and hyperthyroid also can cause telogen effluvium. And the other small points that we need to know about hair and hair loss and diabetes is, hair can be used as a marker to assess the glycation. So how the blood gets glycated to show that the glycation reaction, the HbA1c reaction happens. Similarly, the glycation can happen in the hair also. We said hair grows at the rate of 1 centimeter per month. So the 4 centimeter of hair, if you see, it will roughly correspond to HbA1c. There are studies to validate this point, and if you see 12 centimeter of the hair, it will correspond to 1 year of glycemic control. So tell me one parameter from where we can assess the glycemic control of a patient for 1 year. There is no test at all to do that. So from the hair, we can pick up that point. So even 1 year of glycation can be seen over there. And the moment patients comes with the diabetes and hair loss, what do we say? We put them on lots of vitamins. There might be selenium increased, chromium increased, toxicity of selenium, zinc is decreased. All these things can be assessed in the hair. But what works to our patient is, there are data to show that, yes, vitamin D is associated, but 4 things that we need to remember is, one is iron, folic acid, biotin, B12. So all these things can be helpful in the in regenerating the hair loss. Apart from this, all that we give are just placebo, no data. And I would urge, if one of you is interested in reading about this, please read this article, phenomenally written in simple English to show that how much amount of placebo we pump our patients with. And last point is, there are case reports to show that these two drugs, especially linagliptin and teneligliptin, more with the teneligliptin, many number of articles to show that the moment we start them on teneligliptin, there is an increase in the incidence of hair loss. And also we need to remember there are specific instructions about metformin, because metformin will competitively always fight with B12 for the intrinsic factor. That is the reason B12 is getting decreased. Through that mechanism, metformin also through B12 mediated mechanism can cause a hair loss. So this is something which we need to know. And the moment we say somebody has got hair loss, so see the number of drugs. This is for a simple 23-year-old male who came last week to me with this prescription. So this is the prescription for hair loss, not for any big pancreatic surgery or ICU surgery, means ICU admission, nothing. Just for hair loss, he was getting so much amount of treatment. So this is what our some of us may be treating for hair loss. The psychological stress that is associated may warrant all these things. Let us leave about the finer things. So already surgical colleagues, other medical colleagues also might be telling us your glycemic control is the reason for all these things. Long COVID, diabetes. Cough, control your sugar. Your urinary problem not getting over, control your sugar. Your eye problem not getting over, sugar. Fetal outcome, sugar. Now dermatologists are competing with them also. They might be telling if your hair is not growing, control your sugar. It is all with sugars. With this I conclude. Thank you.
So next topic will be asymptomatic bacteria by Dr. R.H. Lakshmi. She is the director of Hariharan Hospital. She completed her undergraduation from Keelpark Medical College and post-graduation from SRMC, I hope. And her interest is in pregnancy medicine and infectious disease. Over to you, madam.
A very good afternoon to one and all present here. At the outset, I would like to thank the organizers for the opportunity. And yeah, it is always a pleasure following Gauri because he keeps the crowd lively and awake. So it's very easy to follow him in conferences like this. And my job here is to take you through asymptomatic bacteria and diabetes. And as you're all well aware, diabetes is a metabolic cum vascular disease. So we do understand the complications of diabetes with respect to the metabolic, vascular, and iatrogenic complications. But infective complications of diabetes is something that is often seen very commonly in clinical practice and is also something which is sometimes missed when you leave it in the early stages of the condition. And UTI is the commonest infective complication that we find in our diabetic patients. And when you look at the prevalence of UTI, as you can see, it is clearly more prevalent in the diabetic counterpart compared to a non-diabetic individual. And the percentage also is significantly high when there is diabetes. And women clearly outnumber men when it comes to symptomatic urinary tract infections. And the duration of diabetes also matters when it comes to urinary tract infection in a diabetic individual. And when you look at prevalence of asymptomatic bacteria in different populations, as you can see, diabetes again is quite often a major condition wherein you find significant cases with ASB or asymptomatic bacteria, both men and women. But again, even in the diabetic counterparts, women are clearly more represented in ASB than men. And when you look at the clinical profile of urinary tract infections in diabetics and non-diabetics, as you can see, both in men and women, you have a significant number of people that have ASBs in the diabetic population. Again, as UTI is also common in women, ASB is also more common in women compared to men with diabetes. So why are we so much concerned with this entity? Because it carries, any infection in a diabetic carries a high mortality, 10% with sepsis and 42% with septic shock, yet potentially curable if acted upon in time following the guidelines. So why are diabetics more prone for UTI? There could be an alteration in the immune system, both the humoral, cellular, and the innate immunity. The hyperglycemic milieu itself can be responsible, autonomic neuropathy, cystopathy, lot of neurogenic bladder issues that these patients might have. postmenopausal status probably, and the rampant usage of SGLT2 inhibitors of late, all this put diabetics in the spot for urinary tract infection. So with age, female sex, duration, higher BMI, other complications of diabetes, metabolic control, all this adds on to the risk of recurrent urinary infections or even ASBs in our diabetic people. So when you look at the broad spectrum of UTI in a diabetic, you can have one end of the spectrum where you can lie in an ASB status, and the other end of the spectrum which can be symptomatic UTI, wherein you can have an uncomplicated cystitis or a complicated UTI which could lead on to life-threatening infections. So ASB is the presence of one or more species of bacteria growing at a specified quantitative count, irrespective of the presence of pyuria and the absence of signs and symptoms attributable to UTI. And women, 2 consecutive specimens must be obtained, preferably within 2 weeks, to confirm the persistence of bacteria. A lower count of more than 10^2 may be entertained in an in and out catheter specimen. So ASB is very common in women because of the short urethra and the close proximity to the vulvar and the perineal regions, which are usually colonized by enteric bacteria. So all we need to understand is no pyuria and bacteria is just colonization. So therefore, a positive urine analysis does not help diagnose UTI, but a negative test can rule out UTI, which means ASB is largely a lab diagnosis rather than a clinical diagnosis. So the bottom line is that don't test and don't treat without specific signs and symptoms of UTI. If you go on testing urine samples of asymptomatic people with diabetes, quite often you may end up looking at reports of ASB and invariably result in over-treating these patients. So somebody who comes in with a master health check, somebody who comes in with a report like this, which shows a turbid urine with 6 to 8 pus cells with a colony count of say 20,000 for a Kleb pneumonia, I think this is something that should be largely ignored if the patient is asymptomatic. So the criteria for urine testing is the next thing that we need to look at. Test for a urine routine or a urine culture in anybody who is symptomatic, or people with dysuria, or somebody without an indwelling catheter who has fever, hematuria, urinary urgency, suprapubic pain, anything suggesting of an LUTS, then you're justified in doing a urine routine. Or no fever with more than 1 or 2 of the above symptoms, then go ahead and test the urine. Somebody with an indwelling catheter with fever, pelvic discomfort, flank pain, or a costovertebral angle tenderness, rigors, delirium, then again you're justified in checking up the urine. So pyuria is what is defined as more than 10 pus cells in high power field, and bacteria is more than 10 power 5 colony forming units. So a UTI is diagnosed only if there is pyuria, bacteria, and symptoms which are suggestive of urinary tract infection. So urine culture, now I cannot overemphasize the role of urine culture when it comes to diagnosing UTI, because always follow up a urine routine with a urine culture. Quite often I find a urine culture which is done, standalone without a urine routine to go with it. So that again is not a great practice. Always follow up a routine with a culture in a symptomatic person, because you are worried about AMR and antibiotic resistance today. So interpretation of lab tests in diagnosing UTI, be it symptomatic or asymptomatic, again is extremely important. An inadequate report generates more confusion, and the clinical presentation is the most important parameter to be considered. So microbiology of ASB, quite similar to what you find in symptomatic UTI, with most of your gram-negatives playing a very important role. And screening for ASB is appropriate if bacteria has adverse outcomes, and that can be prevented by antimicrobial therapy. So the basic question that remains is that, is ASB associated with adverse outcomes, and whether interventions to treat ASB can improve outcomes? So these are the 2 questions that we need to answer before you actually choose to do more to a patient with ASB. So that said, what is the clinical practice guidelines for treatment of ASB? Whom to treat? You treat in pregnant women, and you treat when the patient is planned for an endourological procedure associated with mucosal trauma. In all other individuals, an ASB may be ignored, and that also includes people with diabetes. So your diabetic patient with ASB need not be treated with empirical antibiotics. So diabetes and ASB, RCTs show that the treatment of ASB did not lead to different rates in symptomatic UTI in future, and rates of pyelonephritis were not significantly different between treated and untreated patients. Therefore, antimicrobials do not reduce the risk of symptomatic UTI or pyelonephritis, and in fact, increase the risk of adverse events. So this is just an article which got published in the NEJM, where they looked at AMR antimicrobial treatment in diabetic women with ASB, and they did not find a lot of difference between people that were treated with antimicrobial therapy and those that were given placebo when it came to ASB. What about elderly and cognitively impaired patients with diabetes? Now, this again is a very, very common clinical entity, right? We always tend to think that any elderly person who comes to you with an acute confusional state or a delirium, vomiting, somebody who's not responding well, there are no major localizing symptoms. The first thing that we always think of is probably this person has UTI, right? That is how we always function, provided all other things are ruled out. So again, also think of UTI, but also keep in mind that there could be other causes which could be playing around in this individual. So think of other things as the first thing that you need to consider. For the bacteriuric patient with fever and systemic signs consistent with sepsis without a localizing source, a broad spectrum antibiotic is recommended and non-urinary sources should also be covered. What about diabetics with indwelling long-term catheter? Urine is generally bacteriuric due to biofilm colonization in people who are on long-term catheters. So that is the first point that we need to remember. And cohort and RCT is done comparing antimicrobial treatment and control population that were left untreated. There was no difference in the incidence of bacteria, incidence of febrile days, and incidence of catheter obstruction. So here again, people with a long-term indwelling catheter do not get carried away by a urine report which shows a lot of pus cells. This is bound to be there because of the biofilm colonization that can happen. So ultimately, what we need to take home is symptom-free P, let it be. So stop treating ASB, it is not an infection. Stop testing foul-smelling, dark urine that is always, thought to be associated with some infective focus. Wait and rehydrate patients who can develop changes in mental status, behavior, or function without, clear-cut signs of urinary tract infection. And go to urine analysis and urine culture if typical signs and symptoms of UTI are present. So what about the consensus behind treating ASB? Now, ultimately, all that we understand is when you over-treat ASB, when there are no clear clinical indications, you're probably breeding a lot of antimicrobial resistance. You're also looking at drug-drug interactions, especially when you exhibit quinolones and OHAs, emergence of resistant strains, C. diff infections, and actually you may push this patient into actual symptomatic UTI, wherein you also have to deal with a lot of AMR. So the only major thing that we need to keep in mind is the emergence of resistant strains. So there are a lot of ESBLs that we even breed from the community today because of unnecessary usage of antibiotics. So the myth is cloudy malodorous urine is always diagnostic of UTI. No, it need not be. And positive urine culture and abnormal urine analysis always indicates a UTI and requires antibiotics. Definitely not. It could be consistent with asymptomatic bacteria. That is only colonization. It need not be an infection. So treatment with antibiotics here is not indicated when the patient is asymptomatic. And positive urine culture in resident with a chronic indwelling catheter always indicates UTI again. No, a chronic indwelling catheter could be associated with bacteria 100% of times. There is no need to treat unless you are convinced that this patient has UTI. Elderly people, again, anybody with delirium, don't jump to a diagnosis of UTI and give an antibiotic. Always think of other causes that could also be responsible for the clinical presentation of the patient. And a follow-up urine culture is indicated to confirm successful treatment of UTI. Definitely not. Once you are convinced clinically that the patient has recovered from an episode of pyelonephritis or urosepsis, don't go on repeating the urine culture thinking that you have to produce a negative culture in order to establish cure. That again is not there in the guidelines. It is okay to give an antibiotic even if it may not be needed. Better to be safe than sorry. Now antibiotics are not like multivitamins where you can just take it in left, right, and center because you do understand the lot of risks that they carry around with. It is hard to ignore a positive urine test even when done for no clearly apparent reason. Definitely not. Treatment decisions should be made based on results, test results, not only on the test results, but also on the clinical picture that this patient carries. So one of the first duties of the physician is to educate the masses not to take medicine, and I would even stress and say not to take antibiotics, because avoiding treatment of ASB is the first step that you and I can take towards avoiding antimicrobial resistance. So this, according to me, is the major 10-year challenge that we all have in front of us, and the first step that we can do in improving all this is to avoid unnecessary treatment with antibiotics, especially in our diabetic patients who come in with asymptomatic bacteria. Thank you for the patient listening, and I'll stop here. Thank you.
Thank you, madam. Thank you for the nice presentation. One more thing to add is, I think within first 3 months of post-transplantation, asymptomatic bacteriuria needs antibiotics. I think so. We will move on to the next session.
Next topic is bone health and diabetes. Speaker is Dr. Namita Narayanan, Professor of Medicine, Chengalpattu Medical College. Expert Committee on Poisoning Management, Government of Tamil Nadu, Field of Interest, Critical Care Medicine, Emergency Medicine, Toxicology and Medical Education.
A very good evening to one and all present here. At the outset, let me thank Anand Moses sir, Vijay Vishwanath sir, Shanmugam sir, and the organizing team for having given me this opportunity. And thank you, the chairpersons, for the introduction. So it is really challenging to talk after Gauri and Lakshmi. So let me see what I can do in the given 10 minutes. So bone health and diabetes. So we all know that diabetes is more prone for macro and microvascular complications, and diabetic bone disease is one thing which is now coming up in a large scale. And as we know, both type 1 and type 2 diabetic patients have altered bone morphology and are more prone for fractures. Type 2 diabetes mellitus compromises bone microarchitecture by inducing abnormal bone cell function and matrix function. And to note is both glycemic homeostasis and bone homeostasis are under the control of common regulatory factors. So the background allows the individual pharmacological targets of anti-diabetic therapy to affect bone quality due to their indirect effects on bone cell differentiation and their bone remodeling processes. I'll take you back to basics because bone remodeling, the bone quality is maintained by the process of bone remodeling, which is a continuous process of resorption which is mediated by the osteoclastic activity and bone formation by the osteoblastic activity. So we all know that the mesenchymal stem cells and the hematopoietic stem cells, mesenchymal stem cells, we have the osteoclast, and mesenchymal stem cells, we have the osteoblast, and hematopoietic stem cells, we have the osteoclast, which then mature into the osteoblast. And then we have this bone remodeling cycle where it goes through the 5 phases of resting bone, activation, resorption, reversal, and formation. So there should be a proper balance between the osteoclast and osteoblast so that the osteoporosis doesn't happen here. And we have so many mediators here, like the estrogen and bone morphologic protein induce the osteoprotegrin expression, whereas your vitamin D3, parathormone, and all the others, they induce the rankle. Rankle inhibits bone formation, whereas osteoprotegrin inhibits the rankle formation there. So what happens in diabetes is there is a diminished remodeling process which is characteristic of the bone in diabetes. So there is a low turnover of bone which leads to defective microfracture repairs and its accumulation contributing to the bone quality. So what happens to insulin? Insulin actually, we know it is an anabolic hormone, thereby it acts on the pre-osteoblast and forms the osteoblast. And without insulin, there is the osteoblasts go more into the apoptosis. So what is the mechanism of development of bone disease here? So hyperglycemia per se can cause increased level of sclerostin, which again diminishes the osteoblast, or it can be due to the advanced glycation end products or the low enzymatic cross-linking. All these put together with endocrine factors of low IGF-1 and parathormone, low bone turnover, and also not to forget about the anti-diabetic drugs, everything put together causes bone fragility and higher fracture risk in diabetic patients. So what happens to the bone mineral density? In type 2 patients, there is a higher bone mineral density, whereas in type 1, it is low when compared to non-diabetic individuals. And we, as all know, bone mineral density is considered the gold standard for diagnosing osteoporosis, and we also have the T-score by which it is measured. And the T-score, we know -1 to 2.5 signifies osteopenia, and anything more than -3 signifies osteoporosis. And we also have the FRAC score, where it is indicated for the fracture risk assessment tool. But here again, age, sex, BMI, history of fracture, parental history of hip fracture, everything is considered but not diabetes. So FRAC score, we need to use it with a pinch of salt when we use for patients with diabetes. And we have specific bone tumor markers again, which are all low in patients with diabetes. So what happens, what is the effect of type 1 diabetic on the bone health? As I already alluded to, there is a lower bone mineral density, which produces changes in bone strength and microarchitecture due to poor glycemic control and long duration of disease. How does it happen? There is a decrease or alteration in the growth hormone and insulin-like growth factor 1 because there is an absolute insulin deficiency. So this causes a decrease in bone turnover and a low BMD. And again, there is a depression of the WNT beta-catenin pathway, which is very pivotal in the role of osteoblast differentiation and regulation of bone formation. The parathormone levels are again low, and which inhibits sclerostin. So all these put together This is what I've given in this diagram. All this put together, we have a decreased bone formation and an increased bone resorption, which is evident by the DEXA scan as we do, where the BMD is low. And due to the onset of type 1 disease in younger age group, along with prolonged exposure to the negative effects of insulin deficiency, we have chronic complications and they're more prone for fractures compared to non-diabetic individuals. And as we all know, the cortical bone accounts for 80% of bone mass and it provides strength to the bone. And the thickness is reduced again in type 1 diabetes. And not only the cortical thickness, the trabecular bone score is also reduced in type 1 diabetic patients. So put together all this and impaired microarchitecture of the bone with decreased strength eventually results in a reduced height for age and reduced bone length, which is responsible for short, narrow and weakened bones, which happens throughout puberty also. So what happens in type 2? Type 2, as I already said, the bone mineral density is increased. Even though it is increased, there is an irregular arrangements of the bone mineral density because the cortical bone mineral density is low and the trabecular there is high. And the other factors contributing towards the increased risk of fractures include abnormalities in bone microarchitecture, bone metabolism and skeletal changes. So again, osteoblastogenesis is affected and all the biomarkers are reduced here. And the CD34 and CD146 markers, which normally has to decrease when the osteoblasts mature, is seen to be increased in circulation in diabetic patients, which again says that there is a immature osteoblasts which are there for the diabetic type 2 diabetic patients. So what happens because of the accumulation of advanced glycation end products? They again prevent normal enzymatic cross-linking of collagen, leading to brittle bone. And there is, again, as I said, there is a reduced expression of all the bone markers. And the advanced glycation end products also affects the vascular system, causing apoptosis of vascular smooth muscle cells. So there is again a delay in fracture healing also. So development of crack-like macro damage in bone causing an increased risk of fracture. And because the PPA receptor gamma is increased, there is more of adipogenesis, and this again causes cortical porosity and also a lower trabecular bone score. So everything put together, there are lower trabecular number, greater spacing, lower connectivity. Though the BMD is high, there is bone fragility. So this is what, to put it in a nutshell, you have increased inflammation, increased ROS and the reactive oxygen species, the hyperglycemia, lack of insulin signaling, everything put together, and decrease in bone markers and increased apoptosis causes decreased bone formation, and the quality of the bone is decreased, though the BMD is normal or more than normal in the type 2 diabetic patients. So differences and similarities in type 1 and type 2 diabetes patients would be a decreased BMD in type 1, increase in type 2, and there is a significantly higher risk of hip fracture in both, and whereas in type 2 diabetes mellitus it is more of hip, spine and forearm fractures. So what happens when the patients have micro and macrovascular complications? So this per se can also add on to the fragility of the bones, because microvascular diseases hasten the deterioration of cortical bones, which causes decreased cortical thickness and cortical porosity, and there is a poor blood supply, which again adversely affects the bone healing after an injury. And patients who've had joint surgery, diabetic patients who've had joint surgery, they have also been seen to have an increased rate of infection irrespective of their HbA1c. So that again many studies have revealed. And again, diabetic peripheral neuropathy and retinopathy, they also increase the chance of falls due to lack of sensation in the feet and decreased sight. So again, there is an increased risk of fall and increased fracture risk, specifically in addition to the expression of negative bone effects found in diabetic mellitus. What about the drugs and anti-diabetic drugs on bone health? As we know, metformin and sulfonylureas, they are prone to have a neutral effect. They don't have any specific effects on bone turnover or bone fragility. Sulfonylurea may cause hypoglycemia, and that can induce fall, so that is again a factor. As we all know, glitazones, thiazolidine has got an increased risk of fracture, especially among women. DPP-4 inhibitors, more research is needed there. Much is not, they don't have any adverse effect on the bone. As such, there are not much studies. But GLP-1 analogs, as we all know, it is insulin, promotes insulin secretion and decreases glucagon. So that is supposed to have an increase or a positive effect on the bone morphology. And still research is needed for SGLT2 inhibitors also. So type 2 diabetes mellitus and osteoporosis, the lifestyle intervention with medical nutrition therapy, and need to ask them to exercise, what we generally tell them, 150 minutes per week, and weight bearing exercises is very essential, and also to cut down on alcohol and smoking, and the diet as we always advise. So type 2 diabetic mellitus, maybe we won't prefer glitazones there, and we'll have to ask them to look for the risk of hyperglycemia, and the drugs preferred would be metformin. As we all know, it has got a neutral effect, and as usual DPP4 and SGLT2 inhibitors. So continued treatment and monitoring is indicated, and there are no specific guidelines for osteoporosis, treatment of osteoporosis in type 2 diabetes mellitus. It is just the same as in other general conditions. So again, other risk factors would be obesity. We know that the BMD is high, but again they are more prone for fractures in tibia, humerus, and ankle. And in people who have a low BMI, we know that they are all more prone for fractures. So to conclude, we have an increased fracture risk in patients with type 1 and type 2 diabetes mellitus, which is multifactorial. It could be due to the clinical risk factors per se, the microvascular complications, the bone per se, which is affected by the disease because of decreased osteoblast and increased resorption, bone turnover and bone mass, there is no equilibrium there, and also because of the advanced glycation products, and not to forget about the drugs, all put together affect the diabetic bone health. So we need to be more careful when we select the drugs, and also maybe we need to advise on bone density to be done, especially in type 1 diabetes mellitus patients. When diagnosed within less than 5 years, we are supposed to ask them to do a BMD, and whereas in type 2 diabetes patients, we don't have any clear-cut guidelines, and we need to ask them to do that on diagnosis, if I may say. Thank you for the wonderful opportunity.
Thank you, madam. That was a nice presentation. Next, we'll move on to the next session by Dr. B. Kannan, sir. The painful neuropathies, what are the new drugs available for the neuropathies? We used to have one of the common presentations of microvascular complication like neuropathy. We used to prescribe like pregabalin, gabapentin, nortriptyline, amitriptyline. So we'll see what are the new options available for the next 10 minutes. Over to you, sir.
Good afternoon to one and all. So first of all, I thank organizing team and dignitaries for giving this opportunity to present this topic. So I will be talking about for another 10 to 15 minutes about newer therapies in painful diabetic neuropathy. So following frameworks I will be talking. So first of all, what is pain? Then what is a neuropathic pain? What is the definition and characteristics of neuropathic pain and pathophysiology? And next, painful peripheral neuropathy in diabetic patient. What will be the character and why it occurs? And lastly, management and newer therapies. With this, I will conclude. So pain, so it is very simple. It's a complex experience. So it is a subjective in nature. It may have somatic mechanism and also psychological influences. We all know somatosensory system. I will talk up one or two things about somatosensory system. So pain is divided into mechanism. According to the mechanism, there is noxious stimuli. Without stimuli, they may have stimulus. And context, it is a physiological or pathological. Sometimes it is a location. According to the location, it will be a somatic or visceral. So normally pain is elicited when noxious stimulus activates the peripheral nociceptor. This is normal physiology. So what is the difference between this and neuropathic pain? So neuropathy, all know it's a disturbance of function or pathological nature now. According to the recent guidelines, neuropathic pain is a direct consequence of a lesion or disease affecting the somatosensory system. We all know somatosensory system. I will touch on one or two points about somatosensory system. So all the chronic pain can be a neuropathic pain. We all know peripheral nociceptors. Very much we will study in the physiology. A beta activated by non-noxious stimuli, and A delta and C fibers are unmyelinated fibers are activated by noxious stimuli. So normal physiology is it is stimulated by noxious stimuli. So this is the neurophysiology of pain. So the stimulus is a noxious or non-noxious stimulus. It stimulates the receptors and causes action potential is generated, and it is conducted to the signal conducted to the dorsal root ganglion. Then it will ascend and the somatosensory pathway spinothalamic tract and enters into the brain. So brain modulates the pain process, and then they descend and end in the spinal cord. So this is the normal neurophysiology of pain. So this peripheral is called peripheral pain response system. This is the central sensitization system. So pain is managed by both peripheral and also central sensitization. So with this background, what will be the neuropathic pain characteristics? So it is a largely clinical diagnosis. So it may be a spontaneous pain without stimulus, and it is a allodynia. So with mild stimulus, we can get the severe pain or hyperalgesia, localized pain to a noxious stimulus, abnormally increased pain to the noxious stimulus. These are the very characteristic feature of neuropathic pain. So epidemiology of neuropathic pain, so around 20 to 25% of the pain is neuropathic pain, out of which around 25% is due to diabetes, and 20% is due to singles, and 30% due to low back ache. So now we move on to the typical topic of painful diabetic neuropathy. So around 25% of the neuropathic pain is due to diabetes. In diabetic patient only, it will be around 11 to 24% as neuropathic pain. So what will be the variety of diabetic neuropathic pain? We all know the very characteristic feature of distal symmetrical polyneuropathy. We get the burning, numbness, tingling sensation over the distal extremities, which is more common than night, which is the very commonest discussion of diabetic peripheral neuropathy. Other conditions also there, acute painful diabetic neuropathy, and acute painful asymmetric neuropathy is due to vasculitis, and also acute diabetic mononeuropathy, which may result due to infarction of the nerves. And diabetic thoracolumbar radiculopathy, they have griddle pain around the waist, and nerve compression, it may produce carpal tunnel syndrome or dorsal tunnel syndrome. These are a variety of the neuropathic pain that occurs due to diabetes. So why we are giving so much importance? So it is up to 30% of all individuals of diabetic have neuropathic pain. So it has poor quality of life, sleep disturbances, lot of socioeconomic disturbances. So you have to be effectively manage the diabetic polyneuropathy pain. So why the diabetes patient will have the pain? So this is, we all know the hyperglycemia produce the microvascular complication and produce the peripheral neuropathy. This all, we already know polyal pathway and variety of pathways will produce, aggravate the neuropathy. But neuropathic pain, it is both peripheral mechanism and central mechanism is needed for to produce neuropathic pain. So we all know mitochondria is one of the organelles which is for energy supplies the energy to the cells. So this is the basics. So normal individuals, the mitochondria produce cell trafficking. So from neurons to the axon, distal axons. This cell trafficking supplies the energy to the distal segments. But in diabetic patient, this cell trafficking signal is disturbed. The distal axons starve the energy sources. That will produce the distal axon is disturbed, and distal axon produce the pain. So this is very common in unmyelinated fibers, mostly C fibers. It is very common. Myelinated fibers, they are very insulated fibers. They will have the Schwann cell. That will supply the energy to the distal axons. This is the basic for the pain in the, one of the pain mechanism from the neuropathic pain. So diagnosis, always clinical diagnosis. So some of the things, neuroimaging, so painful neuropathy patient will have spinal cord swelling, and also some of the areas of the pain sensitive areas in the brain will be hyperactive in neuropathic pain status. So what will be the differential diagnosis? So metabolic causes, infective causes, systemic causes, lot of differential diagnoses are for neuropathic pain. So very important thing is, only two things is very important. Usually vitamin B12 is coexistence with diabetic peripheral neuropathy. So we must be very careful to treat the diabetic vitamin B12 deficiency, because metformin and a lot of drugs will produce vitamin B12 deficiency, which is useful for diabetes patients. And also, one of the condition is called CIDP, that is chronic inflammatory demyelinating polyradiculoneuropathy, which is also having pain. This is also stimulating the diabetic polyneuropathy patients. They are also painful, sometimes painless, both will be present. So now I come to the last topic of management of peripheral neuropathy. So first of all, pain assessment. So a lot of scales are available in the net that will show the how to assess the pain. So treatment, I divided into variety of forms. And what basic is, this is the recent guidelines, ADA, how to treat the painful diabetic peripheral neuropathy. So 5 mechanisms are there. One is non-pharmacological mechanism. It is based on lifestyle modification with energy stimulation, nerve stimulation. Second is topical capsaicin 8% patch. And third is opiates. So because of the dependency, we usually avoid opiates. And the pharmacological therapy, only 3 therapies are available. One is antidepressant, second is anticonvulsant, and third is tricyclic antidepressant. These 3 things are only useful for SNRIs. These 3 only approved drug for FDA. And combination therapy, we can combine with this, all this with this. So this is the basic for diabetic peripheral neuropathy. According to the FDA, ADA, this is the guidelines they given. So these are some of the things. So the time is very short. So young, so the acute painful diabetic neuropathy is common, spontaneous recovery is there. So old age painful diabetic peripheral neuropathy, we have to be very careful because old persons will have already CKD. So the drugs are, we have to limit the drugs of some of the drugs. And antidepressants like amitriptyline, they usually produce dementia, memory disturbance. So we be careful when using the drugs in the old age. So women's acute painful diabetic neuropathy is common. One individual with type 2 diabetes appear to be at great risk of developing peripheral neuropathy. So management, another thing is glucose control. So we all know strict glycemic control for every part of the this forum. We are talk about strict glycemic control. But in a microvascular disease like the neuropathy, strict glycemic control will have very minimal impact in the progression of the disease. So, but some of the studies shows that strict glycemic control will decrease the progression of the neuropathy. So drugs, alpha lipoic acid will have improved neuropathy and reduce pain scores. And aldolase reductase inhibitor, PKC inhibitors also have some deleterious effect on the pain of the patients. So OHA, TPP4, especially vidabiltin, they have some hyperalgesic effect that will be useful for pain in the peripheral neuropathy patients. So we already I told that. So anticonvulsant, pregabalin and gabapentin, SNRIs, duloxetine and venlafaxine, and tricyclic antidepressant amitriptyline. So these drugs are very commonly useful drugs. So we all know these drugs. So with these comorbidities, we can adjust the drugs, these drugs. So topical therapy, 8% capsaicin is useful. And the duration of treatment is at least for 6 months. We can try to give the treatment. The patient is responsive. We can slowly taper after 6 months. So feature, so my topic is now going to what is the feature of painful diabetic peripheral neuropathy. So number of new agents are currently under pipeline. So many of the drugs, so this is a very chart, only one of the chart. I will be dealing with one of this chart one by one. So neuromodulation therapies, so high frequency spinal cord stimulation. So this is nowadays, it is an invasive procedure. We can insert the electrode into the epidural space and we can externally, you can give the stimulus and produce the pain, relieve the pain in the peripheral neuropathy patient. So this is they are inserting the electrode into the epidural space. So next is dorsal root ganglion stimulation. It is more specific. They specifically insert the electrode over the dorsal root ganglia. This is also invasive procedure. This is also approved by FDA. So scrambler therapy is scramble means so reprograms nerve signals, converting the pain signal into non-painful sensation by replacing them with the normal nerve signals. So here the electrode is placed over the externally over the periphery and we give the stimulus. So this will relieve the peripheral neuropathy pain. So emerging pharmacological treatment, sodium channel blockers, lacosamide and mexiletine for refractory cases we use. Then monoclonal antibodies, it is denosumab, it is in the not available, but it is in the pipeline. It inhibits the nerve growth factor and reduces pain in the trials. So cannabinoids is now coming up in the lot of in the markets, and it is very useful nowadays for seizures, refractory seizures, and spasticity in the CNS conditions. So we started 1 or 2 patients with the cannabinoids for diabetic peripheral neuropathy. They saw some good improvement, but the thing is, it is very costly. It is a 160 ml drops. It will be around 7,500 to 10,000 rupees. But it has excellent for all the refractory painful peripheral neuropathy patients. So novel therapy, stem cell therapy, autologous stem cell therapy is useful. We done 1 or 2 or 3 patients for autologous stem cell therapy, but no big improvement. The cost is also around 20 to 30,000 every sittings. We have to do it for frequently for every month, but it is not much useful in our side. So next is gene therapy. So we can give the vectors and insert the vectors into the patient. These are all in the pipelines. It will be coming up in the future. Last is photobiomodulation therapy and transcranial magnetic stimulation. The photobiomodulation therapy use a low-level light therapy which will penetrate and tissues and stimulating the cellular repair and reducing the inflammation. So this is a phototherapy. We give the red light over the lower extremities and patient will have relief of pain. So next comes to the transcranial magnetic stimulation. Here we can give this. It is over the scalp. We give the magnetic field over the brain specific areas, pain sensitive areas. That will give the relief to the pain. DMS is nowadays they are using for migraine, all the pain, and also for it may come in future for peripheral neuropathy also. So peripheral neuropathy reflects the intersection of damage, dysfunction, and regeneration. Its complexity remains as how essential the peripheral nerve is to our sense of connection to the world, both in physical sensation and involvement. So it is a heterogeneous range of manifestation. It is pre-diabetes and metabolic syndrome will aggravate the diabetic peripheral neuropathy. So there is no drug to prevent the diabetic peripheral neuropathy. So intensive diabetes therapy completely prevents neither development of diabetic neuropathy nor its progression, and efficacy of symptomatic treatments for neuropathic pain is limited. There is continuing need for the development of novel drugs tailored to target the pathogenic mechanism underlying the various medication. Thank you, one and all. Thank you.
Thank you, sir, for an excellent and elaborate talk on the painful neuropathy. Thank you very much, sir. For the last topic, I think it's diabetes and oral health. It's another ignored problem of diabetes. I now call upon Dr. Prashant Tarun to talk on diabetes and oral health. So I have his CV. He's a senior consultant physician from MB Diabetes and is an SRM Eminent Alumni Award winner in 2023 and RSD USV Award for Innovative Diabetes Care in 2023. Yes, he can move on.
So thank you, track organizing committee, for having me here, and I'm really happy to see that the hall is full. And today we're going to be seeing about diabetes and oral health. Because so we talk about the heart, kidney, stroke, we talk about everything, but oral health often is neglected by the patients. I won't say doctors, but the patients, because you tell him that he has a kidney problem, he'll be scared. You tell him he's got some other problem, he'll be scared. But when you tell about the oral hygiene, he'll say, doctor. That will be his main first point. And poor glycemic control increases the risk of severe periodontitis in people with diabetes compared to people without diabetes. So as the HbA1c goes up, the risk of periodontitis also increases. more than 90% of the people with diabetes suffer from oral complications where periodontitis is more common. In India, more than 90% of the people with diabetes have periodontal destruction. And prevalence of severe periodontitis in patients with poor glycemic control is 61.3%. So according to the global disease burden data, the periodontal disease is the 11th most prevalent condition in the world. And periodontitis is the 6th complication of diabetes. So we have to give importance for oral health in diabetes. Oral health and diabetes is bidirectional. So like they're friends. So diabetes increases the probability of developing or advancing to periodontitis by 86%. And severe periodontitis increases the risk of type 2 diabetes by 53%. So the ADA recommends referring to a dentist for comprehensive dental and periodontal examination. It is always important for us to ask the patient when he's last visited the dental doctor and tell him annually it is very important that he goes to a dentist. So hyperglycemia's impact on oral health, oral cancer, periodontal diseases, early tooth eruption, caries, dry mouth, tooth loss, candidiasis, delayed wound healing, iron precipitation in the dental tissues, and other diabetic complications. And impact of poor oral health on diabetes, it increases the diabetes complication because of poor glycemic control. It also causes local and systemic inflammation, infection, reduces the insulin sensitivity. So diabetes increases the inflammatory events in the periodontal tissues, impair the new bone formation in response to the bacterial challenges. So as I told you earlier, they're friends. So you take care of one, the other is taken care by itself. So the shared risk factor between the oral health and diabetes. So we take, whereas when address one condition, the other condition is actually saved. So diabetes and the periodontal issues increase in inflammatory mediators such as IL-6, CRP, TNF-alpha, and there is decrease in the anti-inflammatory mediators such as IL-4, IL-5, IL-10, and adiponectin. So because the immune system becomes less efficient, making both these conditions highly susceptible for inflammation. So when diabetes, when combining with the periodontal bacteria causes inflammation, what happens is there is increase in the alveolar bone resorption, increase in the periodontal tissue breakdown, reduce in the alveolar bone formation, and there is reduce in periodontal tissue repair, and all this together causes periodontal disease. So diabetes results in increased inflammation reflected by an increased leukocytes and increased cytokine expression as well as change in bacterial composition that enhances the overall pathogenicity of the microbiota. So hyperglycemia worsens the periodontal health. Higher the HbA1c level means greater the risk and faster the progression to periodontitis. This is a study that shows the risk of macroalbuminuria was higher, the risk of ESRD was higher in people with moderate or severe periodontitis. This is another study that showed where hyperglycemia for a long duration harbored higher abundance of karyogenic bacterium Streptococcus mutans, and these particular karyogenic had even twice abundance in cardiac patients. So basically hovering them actually increased the risk of heart disease as well. Those patients with periodontitis needing dental surgery have 29% greater risk of future development of diabetes within the 2 years. And people with diabetes had twice the risk when compared to people without diabetes. So treatment for periodontitis, one is non-surgical treatment like deep cleaning, extraction of the diseased tooth, periodontal surgeries. So these reduce the cumulative inflammatory burden in people with type 2 diabetes. So non-surgical periodontal therapy in type 2 diabetes led to significant decrease in the inflammatory markers. And the mean HbA1c was 8.1 in another study where they had controlled periodontal treatment, and both the groups, where one group was controlled periodontal treatment, the other group had intensive periodontal treatment, and after 12 months there was HbA1c reduction seen in the intensive group. Another study that showed periodontal treatment significantly reduced the HbA1c in 3 and 6 months. This is another study that showed HbA1c levels dropped from 8.6 to 7.4 post extraction. That is 3 months, and then 7.3 after 6 months. So what happens is this periodontal infection, because of the bacteremia, because of the inflammatory response and the immune response, it affects not only the heart, but it also affects the brain, kidney, liver. So oral health is actually very important, and we should make sure that our patients really understand this. So for that, we really need an interprofessional collaboration, that is referring to a dental checkup. When the patient goes to a dental surgeon, chairside screening for diabetes, in case he suspects diabetes, we have to educate the patient the importance of oral health, because they need to know that our kidney, brain, all that is yes, but still oral health should not be neglected. So there should be a collaboration between diabetologists and dentists. So thank you. I think I finished in 6 minutes. I've saved 4 minutes.
Thank you, Dr.
Thank you.
Prashant, for a crisp, informative talk. It's an excellent talk. And if time permits, I think we can take few questions. Yes, sir.
So regarding the first topic by Dr. Gauri Shankar, regarding this alopecia areata, many a times if you do a KOH study on the scraping of the skin, you will find positive. So simple alopecia areata need not get panicky, sir. Number one. Number two, even if you don't see KOH in the scraping, you just take 1 ml of Kenacort injection, sir. In that, you take 0.1%. And intradermally, you inject for about a week or so. Within 2 weeks, you'll see the hair growing.
Correct, sir.
This is, I have been doing this for a many number of years. So this is one thing I want to share with you, sir. And regarding this asymptomatic bacteria, definitely, madam, if you take the tip of the catheter, 101% you'll get bacteria, not 100%. Yes. But if you really want to confirm it, you do a blood culture. Definitely. So this is the recent article which I was going through, which said you do see asymptomatic bacteria, but definitely a blood culture will settle all the issues. I hope I'm correct, sir. And
So when you suspect, might as well.
madam, do you think this chlamydial infection in females is going to produce asymptomatic bacteria?
You may find a lot of epithelial cells,
Yes.
but you may not.
Mike.
You may find a lot of epithelial cells when you have a chlamydial infection, but when
By voice, no
correlation
volume,
with asymptomatic bacteria, I am not aware with chlamydial infections. If sir is aware, then I will be happy to know.
Yes, the chlamydia infection is not that common, sir. If at all there, that is not going to give antibiotic for the chlamydia.
No, we are not going to give antibiotic. For asymptomatic bacteria, that is also one of the reasons I'm just pointing it out. Sir, in diabetic neuropathy, gamma linolenic acid, 600 milligrams, along with the standard of care. And if one is not going to act, you add 1, 2, 3. And whatever is the blood supply, the endoneural blood supply is compromised in diabetic neuropathy. If you can improve it, it's a great amount of pain can be reduced. So these are my observations after going through all you people. You are all pundits. So whatever I thought I can share with you, I thought I can share with you, sir.
Thank you, sir. Thank you.
My question is about endocannabinoids. It is coming up in a very big way, and I think we should adopt it. Not talk. My voice is little down. So the thing is, endocannabinoids in erectile dysfunction, in Parkinson's disease, it's got multiple roles. So what about the use of cannabinoids? It's available from Sun Pharma. So we should not look at the cost, but endocannabinoids are useful in neuropathy because patients are not responding to gabapentin and pregabalin. And we have to use 600 milligrams in Indians, which we don't use. So what would be your thought, Dr. Kannan?
Sir, I have only limited experience. The market it is only 10 months only it is in the market. Actually, they come for Parkinson's and refractory seizures only. But now they change it to migraine headache. They now change to refractory pain. They say this is neuropathic pain. It is refractory, not diabetic. Still, they are not in the form of diabetic peripheral neuropathy. But they say that refractory pain, most probably a neuropathic pain, low backache, migraine. That pain, now they come back, sir. But till another 1 or 2 years, because addiction is the only problem. But now this molecule, they say that there is no addiction. And also Indian government is also now willing to that cannabis productions from agriculture point of view. Now Indian government is also now wanting, because it is very costly. Now it is 60 ml, it will be around 10,000 rupees. So every day we can use 0.5 ml BD. That is the dose for that. 0.5 ml BD. So very fast, and Chennai it is very coming very fast. Periphery we are using 1 or 2 patients from Chennai referral. They have something, but I am not using, sir. Still not in users. But Sun Pharma is now promoting, sir. 4 to 5 companies are come, sir. Not Sun. 4 to 5 companies are come very fastly. They are coming. They have a post-stroke pain also. We have thalamic pain, that is spasticity pain. They are very severe. CRD, complex regional pain syndromes. They are very severe. Nowadays they say that they are all very good thing. And also diabetic peripheral neuropathy pain is usually 50% only controlled by these drugs. Another 50% patient will lifelong they will be suffering. So this drug will provide good in future, sir. Thank you.
Yes, sir. It's a very nice point, sir. I'll congratulate all 5 presenters. Excellent presentation, Dr. Gauri and all. The tapentadol is a drug which is very effective. When you use gabapentin, you go tricyclic antidepressants or NSRI, SNRIs, you're not effective. Tapentadol is the one which is very effective, but it's not very costly. Like, no, it's 50
but
rupees.
actually, there are 3 to 4, 5 days only they want to use, sir. Because it is not continuously we can't use. Yeah. 3 to 5 days.
One problem with the diabetics is, a diabetic patient who is alcoholic and taking metformin, having severe neuropathy, you think of that B12 deficiency also can cause, because diuretic effect of B12, that is alcohol, cause B12 deficiency. Whenever they comes with the hand burning, and hand pain is more than the leg burning, think of vitamin B12. Supplementary vitamin B12 improves in addition to the support treatment. And usually diabetes affect the small fiber neuropathy, whereas vitamin B12 large fiber neuropathy. Any person with imbalance, there is disproportion to the pain, think of vitamin B12 because it is treatable. And again the metformin, anybody who's more than 2 grams of metformin per day, they are prone for vitamin B12 deficiency. In addition to the diabetic control and neuropathic drugs, probably you can consider those situations. Thank you, sir.
Thank you, sir. Thank you. Sir, nowadays it is not available in India, sir, but anesthetists are now they are using, sir, epidural space they are using for low backache. But we are not very fond of using peripheral. The basic thing is, sir, in diabetic peripheral neuropathy, peripheral system is out, sir. So peripheral system, nervous system is gone. Only spinal cord and above is the functions. So we have to reduce the pain by this only. So this is all invasive procedure. But TENS, transcutaneous stimulation, one method is there, sir. That will produce pain reduction. But you have to give prolonged, sir. So one sitting it won't improve. You have to improve for 10 to 3 to 6 months. Then only they have the improvement. So these are all first two procedures are invasive, sir. Mostly for pain, already infection, it is very not much use in our side, sir.
Sir, in the case of elderly people having falls or this, one more thing we have to add to it is sarcopenia, sir, because that is most debilitating problem, compounding with other vitamin D deficiency. The only problem in our country is vitamin D is not being exploited entirely, sir. vitamin D3 is not been exploited entirely. Because we see all people are sitting in the AC room, they don't get vitamin D3. Even you and I may not get. I was tested, it was only 20. So this is one thing we have to take it to the public. And one more thing regarding the dental hygiene, the easiest thing, sir, let me tell you, plaque formation. Plaque formation. If you catch the person at that stage and you deplaque him, he will never go for
Definitely.
periodontitis.
That's one of the reasons that the collaboration with the diabetologist and the dental surgeon needs to
Sir,
happen from
in
your
my
OP.
practice, without opening the mouth, I don't send any patient out. I
Exactly.
see all the oral cavities.
That was my last slide.
And I will start examining the patient right from the foot to the head, not other way around. That is the
As
best
long as we
way.
examine, we are all
I think
happy.
so that is the best way you can
Yes.
try to do things, sir.
Exactly.